enthusiastic researchers. I'm trying to shift this slide. Shift नहीं होता है. So my presentation is purely from a clinical researcher's point of view. And I don't know how many of you are clinicians, but I know that whatever all of you do, you would like the clinicians to understand and undertake clinical trials. So why is it important to focus on the challenges that we face in clinical trials in women? Because women form 50% of the world population and 50% of the workforce. Clinical trial designs often do not consider effects of and effects on menstrual cycles, contraception, and sometimes these alter the interpretation of the results. If a woman conceives during the trial, consequences of abortion, or when she becomes pregnant, she runs a natural maternal risk. And then after delivery, the long-term effects on fetus and offspring. So actually, it is important for everyone, and it is important for the future generations also. Now, unfortunately, not only pregnant women, but all women are somewhat vulnerable. Socioeconomically, many are disadvantaged in most, if not all countries. Usually, they have to bear the responsibility of using effective contraception. They also have to run the risk of pregnancy and labor. And one requires a good socio-economic contact and a good rapport for better follow-up visits. The main variables to be considered are the phase of the menstrual cycle, what contraception she is using, whether it is oral, systemic, local contraceptives, spermicide, condoms, natural methods, because all these are going to affect at least some of the drugs trials that you might undertake. What is the frequency of sexual intercourse in that period? So what I'm going to do is I'll give a few small examples. For example, we were trying a postcoital pill, and out of the women who opted for it, few women got very irregular cycles. And when we inquired, we observed that they had very frequent sexual intercourse. So actually then the recommendation has come out now that it is not to be used. Here you can see, instead of taking a daily contraceptive pill, postcoital pills can be used infrequently. But if it is not explained to the woman, and if the woman is not selected properly, if you give it to every woman that comes, then they might use it so often that their whole menstrual pattern becomes upset. Secondly, there could be associated reproductive tract infections, local microbicide use, and they have to depend on their partners for the cooperation. And pregnancy and lactation have to be considered, that usually everyone knows, the age and life cycle phase. Now, associated heavy menstrual bleeding and anemia are frequent accompaniments in 50%, not only in the developing countries, but also in the developed countries. And again, whether they have any medical or surgical problem, we have to find out. So I'll be giving some examples that in my long career of almost 4 decades, I have come across. We studied long back kinetics of contraceptive steroids and different drug delivery systems, their levels, and their interaction with other drugs. Out of these, I'll be giving some examples. What I want to point out here is, because we have to consider the menstrual cycle, because I was particular that each woman should be her own control. Then we have less variations. And because we wanted the correct results, each study had to be separately designed. We had to consider the indications, contraindications, and pharmacokinetics of the contraceptives as well as the concurrent drug which we were studying and the ethical aspects. And then that is why one cannot be have a narrow point of view. You have to have some collaboration, out of the box thinking that if I am not able to get my clinic clientele suitable volunteers from here, I might have to go to the leprosy hospital, I might have to go to the tuberculosis hospital. I went abroad for some experimental studies, and across there was also another hospital. So, for example, just if we consider anti-tubercular drugs, now triple anti-tubercular therapy was being used very commonly at that time. And although it was known that rifampicin might affect the levels of contraceptive steroid, there was no data on the levels of steroid contraceptives when women were on the regular PAS, INH, and streptomycin therapy. So we went to TB hospital. We enrolled women who were under treatment for 3 months. And in them we studied PAS levels before starting OC. Then we gave them oral contraceptive. All this, of course, after ethics committee permission and all, and under the supervision of the tuberculosis specialist. And so we did PAS and norethistron and ethinyl levels in that. However, I was collaborating with KEM Hospital for the drug levels, and there the pharmacologist told us that PAS interferes with the levels of INH. So for that, we had to enroll another group. And again, in these also, the same women were studied before and after starting OC. However, here we use single dose studies because as far as possible, my attempt was also to see that steady state levels are studied, both with the steroids also and with the drugs also. However, in some cases, we didn't have an option. And again, same for there was no data on rifampicin levels per se in OC users. So we studied that also. So here are some results. And I can just show here that with triple anti-tubercular therapy, regular routine, there was no change. However, we know that many patients may not respond and you have to add rifampicin. And when rifampicin is added, doubtless, there was a decrease in the steroid levels. Now, both PAS and INH did not show any change with the oral contraceptive. Similarly, we studied with chloroquine. Now, chloroquine again, at least in India, it used to be used extensively as in prophylactic dose, weekly prophylactic dose. So we studied both before and after taking oral contraceptive. And we also studied the chloroquine levels as well as the oral contraceptive level. We had also analyzed the intersubject and intrasubject variations. Similarly, for studying the PAS, the dapsone interaction, we had to enroll 4 groups and conduct some in vitro experiments also, because 2 pregnancies had been reported with dapsone treatment, but with higher doses. And here we were using mainly for leprosy doses up to 100 milligrams. And we did not find an interaction, a significant interaction. Another example that I would like to give is, I was a clinical trial monitor for a phase 2 study on vaginal microbicide for anti-HIV actually. And it was a multicentric, multinational study. Women volunteers were healthy young women either using combined doses or vertebrotomized, and they were keeping symptom record. They were examined, including colposcopy, which is a microscopic examination actually of a magnified view of the local vagina to see whether there is any irritation, because the possibility is that if the uh, agent that you are trying itself is likely to increase vascularity, then the chances of HIV contraction also are increased. So one case was reported to discontinue because of intermenstrual bleeding. However, her colposcopy remained normal when she was studied at the end of the treatment. So I observed that this woman was on oral contraceptive and requested the social worker to contact the case. She had traveled and she actually had traveler's diarrhea, and probably the absorption of oral contraceptives was reduced during this period, and this had resulted in BTV because the vagina did not show any irritation. So unnecessarily we would have attributed vaginal bleeding to the microbicide when actually it was because of reduced oral contraceptive levels due to the diarrhea. Now these are not studies by me, but they have been reviewed very well over here, and it is necessary that all of you know about this, because different drug delivery systems are involved. This is a 3 monthly injection of dipomedroxyprogesterone acetate was used, and they had reported accidental pregnancies in them. So then it was thought that, sorry, the injection in very obese patients, the injection needle was not reaching, because if the fat layer is right up to here, you can see that the injection might be given into the fat. And that is why, but later on, of course, when they came to know the cause, the technique was changed. Either longer needles would be used or injection can be given in the deltoid. Currently, a subcutaneous lower dose is available with less side effects also, because there are already always improvements. Another example is ulipristal acetate, which is an emergency postcoital contraceptive, which shows reduced efficacy as the BMI increases. Why I am emphasizing is because obesity is known to be more common in women. Now, I have conducted research in complementary and alternative systems also, particularly with respect to Ayurvedic medicine. And the rigor with which we conduct this research is no less than whatever modern uh, or allopathic medicine we would be doing. So I thought I'll show you some examples from here. This combination pill of two plants and one other preparation was used as a contraceptive pill in an Ayurvedic hospital, and we decided to study because they used to start during the lactational amenorrhea itself anytime, and they did not consider the anovulatory period in lactational amenorrhea, so they thought it was quite effective. Now, the contraceptive efficacy is only tested when regularly menstruating women are cohabiting with their partners for a long period. So in these we studied the pap smear for hormonal cytology, the cervical mucus, the Puan test. In some women, we even studied the postcoital test and the endometrium, and everything was positive as in a normal cycle. So finally, they stopped giving this pill. Later, a 3 times dose was proposed. That is a little bit of problem with Ayurvedic texts because they don't mention the dosages and the durations, but some of them are very effective, and we have to spend more time and thought into conducting these studies. And here you can see another Ayurvedic preparation. This Ashoka Rishta oral liquid was being used twice daily in women with excessive blood loss, and it was controlling according to them. And the company came up with an oral formulation which is much easier to take. So they wanted to see whether this is also effective. So we excluded organic causes because you need to exclude fibroids, polyps, and things like that, serum TSH for hypothyroidism, platelet counts for thrombocytopenia. We gave all women the pads to be used from the same company. The days of bleeding and clots all were recorded. And sure enough, in 24 women, it was reduced. 6 women, however, who were anovulatory, so who had irregular bleeding and hormonal imbalance, did not respond within the 3 month period. So, some of the Ayurvedic medicines are very effective, and in these women, some were able to avoid a hysterectomy, which would have plus the loss of an organ unnecessarily because it is dysfunctional bleeding. So, but they need to identify the subsets within the condition which would really respond, because this may happen with other treatments also. So this was another vaginal douche which was studied as a microbicide for cervicovaginal infections, and we studied the vaginal pH as well as the pap smear. You can see the clearance of the infection, and here also, if the method of collection of pH was not followed proper, and if the pap smears were not collected correctly and as per the cycle days, we would not have detected the effect, which is the true effect that we found. Of course, there were uh, failures, and in a future study which I have not shown, we compared a vaginal gel containing the same combination, and there are failures with modern therapy also. About 10 to 15% don't respond to your treatment. This is another study where I thought uh, the study of the women, both the history as well as the examinations, have to be done in the same time, and then only you can see the difference. There was a regression. This was a very recently completed study, and you can see the regression in nuclear changes, and we are saying we have given integrative treatment because usually there are associated infections. So we give the antimicrobial course that is recommended by the national guidelines for infections. And then those abnormalities which persist after treatment of infections also, they have responded to a standardized turmeric oral extract. Now here I think the challenge was that because the condition is not so common, women find it very difficult. Please remember that they have young children, toddlers, to leave those and to manage the family and then to come. So it's not easy. A very large number of women had to be screened and followed up. Some of the follow-ups from one of our earliest studies have been coming for 2 years, 3 years, 4 years. So those were the examples I thought. Now here, this is again not by me, but Dr. Badwe and others. And even now, timings for gynecological surgeries are known to alter the outcome. So planned surgeries are usually carried out accordingly, most of them in the post-menstrual period, because the vascularity is less. However, people had not thought of this during cancer treatment. And Dr. Badwe studied the estrogen and progesterone receptors and the effects on immunity and vascularity. And he showed that there is long-term survival in breast cancer cases and how it improved. And this was published, I think one of the studies was published in the Lancet also. So even if it is cancer, there is no need to get worried and for immediate surgery, as sometimes it can help to postpone the study as per the menstrual cycle. Now, these are some other good publications that I came across, so I thought I'll just briefly review. Then This was for cardiovascular disease mainly, and they said that there are different outcomes and different pathologies. More plate erosion and more diffuse plaques are seen in women. Then, when there are bone marrow progenitor cells draft, one should look into the sex of the donor cell as well as the sex of the recipient. So, research should be aimed at evaluation of sex-based differences. Pharmacogenetic studies, genomic studies also should be included. This is another summary that I thought everyone should know about. That I mean, this factor even we have reviewed in 2013. I'll show you some of the things from that chapter. That less women are enrolled in clinical trials, and particularly pregnant women or lactating are not studied at all. And then when it comes, because diseases don't differentiate. So if a pregnant woman becomes treatment, it becomes very difficult to decide whether to give treatment to this lady or not. And that hampers the treatment. So there is low enrollment of women. This should be encouraged. However, as I said, one has to be careful, and one has to take all the precautions that are necessary. And so this was emphasized. However, I found that both these summaries did not emphasize on the timing of investigations or examinations or treatment also. I would like just give one more example, that even treatment, for example, for a chronic disease, even treatment should be postponed. For example, if I have to treat sexually transmitted disease or a genital infection, which is chronic, she has been having it, say, for 6 months, 1 year. Then instead of immediately treating her, it is better to postpone treatment to the post-menstrual period, because post-ovulatory, there are chances that the embryo might be affected by chance if she is pregnant. So we try to follow this good clinical practice as far as is possible. And these precautions should be taken during clinical trials also, whenever possible. So yes, this was the chapter that I said I had referred to. And 3% of all congenital defects. But as we know that these may turn out to be tens of thousands or more if you consider the whole world. And if all of us take all the precautions, like some of the precautions, one thing that I mentioned, that as far as possible, if it's a short course, if you can avoid treatment during the post-ovulatory phase, then even then some of these congenital defects may be reduced. You never know, because these are the gross congenital defects. Then we also don't know, there are some defects like hypospadias or homosexual behavior was suspected in male progeny after only long-term follow-up up to the teenage pregnancy. And unfortunately or fortunately, the number of pregnant women taking medicines has increased. 4 or more medications has increased from 23 to 50%, and must be still more, maybe still more. So, in summary, I would like to just say that distinct challenges are faced, and it is necessary to include in all case records menstrual cycle data, date, cyclicity, amount and number of bleeding, and contraceptive type, and whether there is a failure. Because to my mind, if we don't have these records, we will never come to know the subtle side effects of some of the drugs which we give for 1 year or 2 years, like effects on menstrual cyclicity or menorrhagia. I remember a case report where sesame, simple, one woman must have started it just for health, good health, sesame or til as it is called in Ayurveda, some one spoonful or two spoonfuls every day, and it caused thrombocytopenia and menorrhagia in that woman. And that was a very good case report where they followed up the woman, they discontinued, then her thrombocyte count came to normal, and fortunately for them, the woman agreed for a re-challenge. And when they re-challenged under supervision in the hospital, they again found that there was thrombocytopenia. So we need to be very, very careful. So that is why it is necessary to train all investigators, whether they are men or women, in recording this history. Either they can ask themselves or through the social worker, whichever way. And the timings of these investigations, timing of treatment or timing of surgery with respect to cycle phase is important. Yes, I think I have already discussed these examples. Even IUD insertions, I have found that in national programs earlier they would do anytime. And secondly, without treatment of the coexistent reproductive tract RTI, any infection. However, that is the uh, mistake that is made, and that causes pelvic inflammatory disease in women who were earlier healthy. So we would like to avoid such problems. Uh, of course, I will say that none of this work was possible without my mentors, for whether it was cytology, clinical trials, medicine, Professor Breckenridge. Then these are my current mentors, and this is the current junior team which is working with me. Also, I would like to thank all the basic scientists, because I have equal respect for the laboratory scientists who developed the methods and also who develop new diagnostic methods or standardized assays. I know, but I feel that even they should understand why it is so difficult for the clinician to enroll women fast. They should not pressurize, otherwise, wrong people will be enrolled, and one might get wrong conclusions if proper records are not keep, kept. And also I must thank all the women who participated in the studies and the social workers who kept a very good rapport with the women. Thank you.